We need to start. Assalamu alaikum. This is Azhar Ali on behalf of Giving Back Pharmacy in Pakistan. We are on webinar session, and the topic of our session is diabetes management, patient assessment tool, and motivational interviewing skills for pharmacists. So, a little bit about myself. I am graduated from Rifa International University, Islamabad in 2014, and after that, I joined Arfan University Hospital for training, and then I confirmed as a pharmacist in Arfan Hospital, Karachi, and after that, I'm currently working in Ahad Healthcare, which is community setup in Pakistan. So, major focusing on the to develop a primary care setup regarding the community pharmacy in Pakistan. So currently I'm working here as a manager pharmacy. So regarding the today's session, just a little bit about the diabetes in Pakistan. Between 2010 and 2013, it was stated in one of the study that there will gonna be a 67% surge in diabetes, and 49.7% of adult diabetes are still undiagnosed. And according to one of the survey, 26.3% above 19 year are known to diabetes. So diabetes is a major threat in Pakistan. So we arranged this session for you. Today we have two respectable guests with us. I'm introducing one by one. First, we have Dr. Syed Wasif Gillani. A little bit introduction regarding the Syed Wasif Gillani. He did his B Form from Pakistan in 2006. Then he did a MSc in clinical pharmacy from University of Science Malaysia in 2009, and then PhD in clinical pharmacy from same university in Malaysia in 2013. After that, he worked. Currently, he's working as a acting chair, Department of Pharmacy Practice, Master in Clinical Pharmacy Program Coordinator, and Associate Professor of Pharmacy Practice in Gulf Medical University in Middle East. And then the second one is Zeyad El-Gamal. So I would like to introduce him before his session. So we are going with Syed Wasif Gillani. Next, you have Wasif Gillani in today's topic.
Thank you, Azhar. Should I'm going to share my screen now?
Yeah, sure.
Okay, is it visible? And am I audible?
Yes, you're visible and you're audible.
Thank you very much. So I'm going to start up now. First of all, thank you very much, the Giving Back to Pakistan Forum, for providing me this opportunity to talk with this prestigious forum and in front of all the Pakistani fellows, the experts, and the pharmacists. Thank you very much. So I'm going to start off with my topic. I'm supposed to talk about some patient adherence and understandings and tools in today's session. And this is my disclosure. So what we are expecting that the end or at the completion of this activity or this lecture series, you are able to understand the concept of adherence, the factors that are affecting the adherence. There are strategies the pharmacist is supposed to do. What are those strategies? There are workup assessment methods. What are those methods and how we are going to reinforce those methods in the practice side, and followed by the application or the available tools for research purposes in the in pharmacy practice for diabetic care and the other cares. In the era of medical sciences, the Hippocrates were considered as the father of medicines, and it goes to 460 to 370 BC. So the term adherence was first identified in that era when they find out that the patient, they were deviating from their prescribed medication regimen. They are deviating in terms of any sense. They are underusing it, they are not taking it, or or they are skipping whatever, they are deviating from the prescription they're supposed to be. So from that moment and onwards, the word adherence is being a controversial in the scene, and today we need to discuss what is actually adherence and how we are going to work with it. So eventually, we need to understand one goal first when we talk about adherence. Uh, what we expect, or what would be the outcome when a patient is adherent? So when we use a word adherent, an adherent patient, it means that the patient uh, has a good safety. The patient safety concerns are there. The patient has a good clinical or health outcomes are achieved. Patient has improved quality of life. This is what we expect when the patient is adherent. And comparatively, when the patient is a non-adherent patient, the treatment inefficiency will be seen. There will be increase in morbidity and mortality rates in the patients, and as well as the hospital cost or healthcare cost will increase on this. So when we talk about this thing, we will say that adherence is kind of a multifaceted parameter. It's not a single parameter. It's a multifaceted. It has a lot of dimensions, determinants. They have diversity. Now, those diversity primarily based upon the patient's satisfaction, patient's belief to the medication, patient understanding to the disease, what disease they have. And all these parameters eventually uh, make up their adherence level to the therapy. Now, some peoples, they were very confused about the word adherence. When we use a word adherence, uh, they thought that the adherence is a word uh, used as an interchangeably with a word persistence, or an interchangeable word to compliance. So there are three basic concepts that we really need to understand. That consistency is not adherence. Consistency, a patient is taking any drug regularly and prescribed time. uh, would be, you think that it would be an adherent condition? No, it would not be. So let me give you one example. So if a patient who is taking any antibiotics uh, at defined prescription, okay, we can say that this person is persistent, is not adherent. Why? Because there is another factor, and we called it drug related problems, that the antibiotics that person is taking, what about the doses of it? What about the appropriate dose? What about the underdose? What about the other drug interactions? Now, back to the previous slide, when I told you that when we expect a word adherent to a patient, we need to understand a adherent patient supposed to be safe. The medication should be in a safety. The medication gives safety to the patient. The medication will improve their healthcare outcomes. The medication will also supposed to have the improve in quality of life. So if any drug a patient is taking is underdosed or overdosed, these criteria has been not been fulfilled. Similarly, if any patient who are taking drug regularly at a proper dose, or prescribed dose, it is just one side of the story. That's a side of the story of the patient. That this is patient related factor. Patient is taking the dose, what is being prescribed. What is the other side of the story? That is healthcare side of the story. That means the appropriate drug selection, appropriate dose selection, appropriate monitoring, appropriate behavioral interventions. All those things come up in a one loop. So oftenly we see a little barrier between these words: consistency, persistence, compliance, and adherence. And we forget about the word concordance, to the therapy. All these things are not, again, it's not, adherence is not a single or monotonous tool to evaluate the patient conditions. No, adherence is a multifaceted assessment in which there are several dimensions to evaluate and to determine either the exposure and the cause are directly related or not. Okay, so there are still some argument. They say that the adherence tools, they make people, meet their take their medications appropriately. They are working with their medications appropriately. uh, Again, all these words will be more consistent, or they will be more word persistence is more important to that. Now, with this current understanding, now let's have another dimension of adherence. When we use a word adherence, a lot of studies, they have clearly mentioned that around 15 to 25 or 15 to 20% were actually showing uh, appropriate time based refill based on their prescription. So again, my concern again go with the same level of understanding, that is the refill, evaluation of refill or counting of refill or counting of these values is a true picture of adherence? No, it's not a true picture of adherence. Adherence, compliance, adherence, concordance, persistence, all these are quantifiable parameters to evaluate what? To evaluate the patient medication taking behavior. In the end, we are talking about patient medication behavior, and the main goal is that the patient who is taking that medicines, he will achieve a shared treatment decision. Shared treatment decision. Now, let me elaborate this word shared treatment decision. There is a tremendous shift from paternalistic patient relationship. Paternalistic means that patient is passively following doctor, whatever doctor said that or whatever pharmacist said that, they just follow. Now the problem is this is the old model. Now current model is egalitarian model. Egalitarian model is that we involve the patient in a decision making, in a selection of drug, in the in improving their attitude, in improving their knowledge, and in improving their understanding. And all these modifiable behaviors will lead to improvement in their practices, medication taking practices, or health seeking behaviors. Now these things will eventually improve the adherence. Now, so this moment we need to decide that we need to change from 3 basic questions to 5 basic questions. Now, all the times I always told to my students and to my fellow preceptors in our hospitals, there are in practice, there are 3 basic questions we ask to every diabetic patients. Number 1, what this medication is for, what is the purpose of this medication? We usually ask for the counseling. Question number 2 we will normally ask is that, do you know how to use it? How to take it before food, after food, with food? Okay. And the third question we normally ask is the common side effects or adverse drug reactions. Do you know what are the common side effects and adverse drug reactions? So these were the basic 3 questions we use in paternalistic relationship. Now, in egalitarian relationship, we supposed to have 5 basic questions. We are extending those 5 questions. Now, the first question is, do you know what is your disease? Or what is your disease? Number 2, do you know how you are going to do self-care practices? What are your self-care practices? Number 3, the drug you are taking, do you know that it is for treatment or it is for prevention? Number 4, the drug you are taking, do you know that how to take it? What would be the route of administration and how you are going to use it in the case of emergency? Question number 5, what are the possible side effects, adverse drug reactions, and more specifically, other drug and drug interactions? So this is where we have a shift of knowledge and shift of practice. Before the decision, therapeutic decision was taken by doctors only. And that's why we called it its paternalistic model. Now we say that shared treatment decision means that the patient have an equal right and equal contribution to decide its own short-term and long-term goal in collaboration with doctors and pharmacists, and make them feasible and make sure that they are going to do the proper follow-up. And this is where the WHO has defined certain rules. They say that there are total 5 adherence domains. And among these 5 domains, only one domain is patient-related factors. Rest 4 others are not patient-related, but they are more of drug-related, they are more of disease-related, they are more of system-related, healthcare provider-related, or societal related. So this question, actually this domains, give us an other era of understanding. And what is that era of understanding? The era of understanding is whether and why. Now this word whether is very difficult to calculate. Why? Because normally we talk with the patients regarding their adherence issues. We talk to them that, did you take the medicines regularly? Are you taking your balanced diet? Are you doing lifestyle changes? All these questions are subjective questions, and they are purely based on the patient honesty, dishonesty, and their memory, the level of memory. Do they remember to answer this question or not? And different circumstances, this word whether change. Sometimes the patients were traveling and they are often miss their doses. Sometimes they are not traveling, so they are taking the drugs regularly. So if your appointment is near the regular intakes, they will report it, yes, we are taking regularly. If your appointment with the patient is after the frequent traveling visits, then yes, you will get a word, no, often I miss the dose. So these are pseudo values, in my point of view, pseudo values. Patient reported values are always difficult to validate. They have low sensitivity and specificity. Now, the second concern comes, and that is much more difficult for us to understand, is why. Why a patient is not taking care of themselves, why the patient is not taking the medicine, why is the patient is showing this poor behavior, why patient is non-adherence. This word why requires multiple analysis, and in upcoming slides we are going to talk about it. But right now we need to understand that there are 14 theoretical domains um, that actually simplify this problem for us, the patient behavioral problems for us. And these 14 domains were further classified into 2 domains, either modifiable domains or unmodifiable domains. Now, it helps us a lot. So as a pharmacist, I need to focus more on modifiable determinants like knowledge, behavior, and others. And I need to make sure that whatever interventions I am doing on modifiable determinants, they must be tailored or they must be aligned with unmodifiable determinants like the low financial status of the patient, geriatric, old age, geriatric patient. So my focused strategies or interventions should be based on, or it should be made on modifiable determinants. And I need to tailor them, I need to align them based on their unmodified determinants. So for example, let me give you an example here. If the patient has a problem that the patient is not adhere to their medication because of the social influences like disrupted families or their peer pressures or any other thing. So in that case, what would be our best strategy to increase adherence? Family interventions, group programs. This will increase their adherence in that level. Now concern come that we often ask ourselves, and I often, when I look into the literature, I look into different type of researches over young people and over friends and colleagues, and over respectable people and pharmacists. They are doing a lot of research on adherence and patient satisfactions and these things. Uh, and I oftenly look into those research, and I find out that majority of the articles, they are giving conclusion based on a single tool of assessment, and they are just giving conclusion based on a single subjective assessment. And this is where I usually said that no single intervention strategy can improve the adherence for all the patients or any type of patients. All the patients that require interventions, they need to be fully assessed first. You need to assess them first. Individual assessment is required. The problem with this patient non-adherent behavior is what? Is it related to patient characteristics? Is it related to disease condition, related to treatment strategy, related to any other healthcare provider issue, or it's healthcare system issue, distribution issue? And then you are going to do what? You are going to maintain, and you are going to develop a specific plan for this person. Now there are some people who have some issues, like some people, they have a problem in and specifically geriatric people, they have a problem in taking a lot of medications. So usually geriatric people with 4 or 5 medications, it's difficult for them to remember in that age, and it's difficult for them to maintain their regimen. So this strategy for reminder strategy is different. Now there are some people who are skipping, knowingly or unknowingly, they are skipping these scheduled appointments for follow up. So your strategy for these people is different, and first type of people, there is different. Okay, so different approaches are required, or multiple approaches are required for multiple type of cases, and the assessment is very important in that way. Now, participation, engagement, collaboration, negotiation, compromise, all these are the opportunities for us as a pharmacist to optimize the therapy for our patients. And this is where patient, when they engage with you, and when the patient know that they are making their own target goals, they know that they are deciding their own medications, then they will do their responsibility. They will take care of the responsibility in adherence equation. The rest equation, the safety and efficacy of the drug and the clinical outcomes, is the second part of the equation. The first part is the patient related factors. This will be easily overcome and enhanced with the participation and engagement and collaboration things. Now, I often been discussed with our pharmacists, and specifically when our pharmacist is dealing with diabetic patients. Diabetic patients are much more complex patients. The reason is they have a lot of comorbidities, you know very well: hypertension, renal problems, nephro, sometimes micro, macrovascular issues. There are so many issues. There are psychological issues and physiological issues in these type of patients. So the pharmacist strategies, we have a lot of strategies, and we know very well that there are a lot of pharmacist led services are there, like medication reviews are there. There are medication adherence therapeutic clinics are there. There are pharmacist led diabetic clinics are there to evaluate and reinforce the things in the patient understanding. Now, the concern come that we already know, and we already developed a very comprehensive structure of pharmacist interventions in our daily practice in our hospitals. Until now, until now, this adherence issue is still unsolved issue. Even in clinical trials, we will find that the patients are non-adherents. There are a lot of dropouts. There are a lot of skipped uh, conditions. Patients are not uh, you know, taking their drugs. They don't aware of the drugs. Their knowledge, their understanding, their beliefs are not concordant with what we expect with the therapy. So all these factors back to square and back to zero. And we need to again understand that a pharmacist is a key person who improve patients' expectation on the treatment. A patient will never take medicine if he don't believe in medicine. If you will not give them enough education or knowledge that this medication is going to improve what parameters and how it is going to improve, the patient are not going to take it. So eventually the role of pharmacist is basically, in the whole context, is improving the patient expectation to the treatment what they are taking, and also develop enthusiasm in the patient, that they know that what they are doing to themselves, they know that whatever they are doing there themselves is their own decision. The medicines they are taking, they know about their own medication, they know how to use them, and they decided to take them by themselves. Nobody have enforced them to take the medicines. Okay, so this knowledge is very important, and I put here in box 1 some examples how a pharmacist can either reinforce or not enforce the choice of treatment. So this is a perfect example of a pharmacist who is enforcing and who is using an effective communication with the patient and improving the patient expectation, improving the patient behavior. Now, there is another thing that we need to understand, and that is a 360-degree approach. This is the latest understanding of approach to the patient adherence. In this approach, we will use multiple strategies. We will talk about the predictive behaviors. We will do comprehensive review of the real-time data. We will look into the reasons why this patient is non-adherent, and we will look into those analysis to the behavior and psychological values. Then we look into the interventions we can provide them, and those interventions would be very specific to the patient literacy, to the patient education, and we will tell them and it will be mainly focused on the adherence and compliance of the patients to the treatment. Then we look into scaling up of our adaptability, that we will increase over different levels of interventions. We will look into different other things. We will develop cross-functional capabilities. We will look into comprehensive engagement strategies, how we will do the follow-up. Oftenly, I look into the other day I was walking through the hospital, and I see a very beautiful quote written there on the walls, that if your planning failed, then you will revise your plan. You will never change your goal. So yes, this is the point when we say that the plan you prepare with your patient is failed, then you will change the plan, you will change the strategy, but you will never change your goal. You will never change your objectives, your main goal of the therapy. Now, the issue is that we always, and majority of the cases, we rely on the patient reported data. And this patient reported data is very, very poor in sensitivity and specificity. Again, I'm saying only patient specific data is not a reliable way to develop any intervention. We need patient reported data as a support, and we need some laboratory values to ensure that this data is validate and accurate. So either we can use like medication event monitoring system. We can also look into certain type of medication review packages or electronic medication record packages, and all those things we can look into to evaluate. Now, the best thing is that in certain developed countries, now we have a central or centralized medical database. So even if patient is taking or patient is showing self prescribing behavior, wherever pharmacy or whichever pharmacy they will go, it will automatically record into their medication profile. So the prescriber, the pharmacist, the dispenser, uh, all the people, they know what the patient took, when they took it, from where they bought it, how much they bought it, and how much they took it. So it also help us to identify the self prescribing patterns of the patients. Now, there is another very important thing that we really need to work with it, and we need to understand that to improve adherence, we always look into the negative forces. The negative forces means the values or the things that promote non adherence. So, in negative values, we need to work. Nowadays, there is a telemedicine. Telemedicine is actually helping a lot and bridging the gaps between healthcare system. We can also educate, empower, and also encourage the family member or the caregivers to work on the adherence patterns, values. Now, there are certain patients who have a unit dose system or a daily dosing system or an intermittent dosing system. If they have intermittent dosing, and you need to know that the patient is adherent or not. So, if required, you can do a therapeutic drug monitoring to see the appropriate the serum concentration values. This is though very expensive, but in my belief, this is the only objective data after real PCR value or real time PCR, real time values. This is the only objective data. We also have real time data, but I'm going to talk about that. Not all the disease or conditions we have it. And for diabetes, we have real time data. So eventually, if we need to work with on all the aspects, patient psychology, patient behavior, as well as patient medical history, all these three things together with the pharmacist's interventions, together with the appropriate selection of the drug, together with the safety and efficacy, we can actually develop a proper adherence in our system. So now for that system, we really need to look into the appropriate tools of assessments. So what are the tools of assessments normally we used? So the tools of assessments, we have DOT tool and modified direct observed therapy and modified drug observed therapy. This is one of the objective tool. It provides the measuring of adherence because the patient need to come to clinic every day and talk in front of you. There is therapeutic drug monitoring. There is clinician, pharmacist, and nurse estimated adherence. Again, there is a limitation in this because it is dependent to how well patient is sticking with their scheduled appointments. If patient are skipping, then this data will not be validated at all. Pill count,
With,
prescription
we are
refills.
short of time. Kindly, if you conclude, it's a very
Yeah,
brief
yeah.
session. Maybe.
Now I think it's a time. This would be actually the last point. So this is the common questionnaires we are going to use in our practice and for research purposes. Finally, I really recommend everyone please look into this article. This is one of the very important article for all the practitioners. These are the references. Thank you very much. Thank you. Thank you, sir.
Thank you so much, Dr. Wasif, for the brief session regarding the adherence and the pharmacist intervention. So now I would like to introduce our second speaker, Mr. Zeyad El-Gamal. Zeyad El-Gamal, having the vast experience of more than 15 years, Ziyad did his graduations from the School of Pharmacy, Alexandria, University of Egypt, year 2002, and then he moved to Saudi Arabia where he worked for the Johnson and Johnson, and then he immigrated to Canada where he got registered as a Canadian pharmacist, and also have the experience of a certified diabetic educator. He's also have an additional prescribing authority. We will discuss in some other webinar, and he's also a board certified pharmacotherapy specialist. And Ziad have and now Ziyad is currently working as a lead clinical staff pharmacist at Cleveland, Abu Dhabi. So he having a multiple countries experience. He's also holding the certificate of strategic management from the Harvard University and also the Master of Management degree from the Harvard University. So Ziyad, it's now up to you. So have a brief session regarding today's webinar.
Thank you, brother, and thank you, Dr. Wasif and Dr. Muhammad Siddiqui for this invite. It comes with honor and pleasure as well to share the best practices with my brothers and sisters in Pakistan, thousands of miles away. I hope you find this presentation helpful. And actually, it works hand in hand with the presentation of Dr. Wasif. Dr. Wasif gave us amazing big picture and details on what is coming in the pipeline and how we should deal with a patient. And I hope I can add value with this presentation about motivational interviewing skills for pharmacists. Okay, so those are my disclosures. I have no conflicts of interest. And the learning objectives today will be at the completion of this activity, we will describe the stages of patient readiness to change behavior. And you will be able to explain how to match your educational approach to your patient readiness stage. Also, we will identify together and implement the principles of motivational interviewing with your patients. So let me start the presentation with a story. So it's a story of a young child that grew up in a family and his father unfortunately had a bad drinking habit. The father rejected all types of counseling. He didn't think he can change his behavior. And unfortunately, the father died out of the complications of his bad habit of drinking. This little child grew up with one question in mind: how a human being can change a behavior. This child grew to be Dr. James Prochaska. He's one of the 10 most eminent clinical psychologists, and he is the developer of the trans-theoretical model of behavior change. The trans-theoretical model has few assumptions. It assumes that the patient may be in one of 5 stages for patient readiness, which is first stage, which is pre-contemplation, the patient is not ready stage. Stage 2, which is contemplation, the patient is getting ready. Preparation, the patient is ready. Action, the patient already started. Maintenance, and which is the stage that he maintained it for a longer period of time. Another assumption that each stage requires a different tactical approach to convince the patient to change a behavior. And the patient changes a behavior only when he is ready to change, when he is convinced to change, and when he is confident that he is capable of doing the change. I consider those 3 things are the checklist of behavior change: ready, convinced, and confident. Now we'll move to the trans-theoretical model foundations. So we discussed the stages. Now we will discuss the decisional balance. So the patient is hesitant. There is ambivalence. Does he see the pros more than cons? The pros of the change more than the cons, so he will change easily? Or he sees the cons more than the pros, so he sees it's not doable? Now we'll go also to the self-efficacy. That's the 3rd pillar of the trans-theoretical model. Does the patient see himself capable of moving, of doing the behavior change? So a quick reminder of the 3 things that we discussed in the last slide, previous slide. So the stages is the readiness. The decisional balance is he convinced that the pros are more than the cons? And the self-efficacy, it is the confidence. Is the patient confident that he is capable of making that change or not? Those are the 5 stages that we will break them down in details now. So stage 1 is the pre-contemplation stage. The patient is not ready for the change in the next 6 months. He's not even thinking about it. Maybe he failed before. He tried to quit smoking. He was not able to do it. Maybe lack of awareness. He wants to change, but he does not know how. Maybe he is in denial, the one that says, oh, I love my cigarette, or there is nothing called cholesterol. And we need to evaluate those three things: the stages, decisional balance, and self-efficacy stages. He is in the pre-contemplation. Decisional balance, he sees the cons way, way more than the pros to do the behavior change. So he is very low conviction. So he's not convinced. He's very, very low confidence to change. So how to handle that patient stuck in the pre-contemplation stage? We do motivational interviewing techniques, which we will discuss in the second part of this slides. And we raise awareness by using facts, by active listening and catching on the low-hanging fruits with the patients. We can hand the patient some handouts. He might tell you, I don't have time. You can tell him, I'll give you a handout. Read through it. If you have any questions, come back to me in the next session. We can discuss it, because the patient is so resistant. Some examples: you can give a shocking statement to the patient just to bring his attention and create awareness. If the patient is non-adherent to exercise, or he does not believe that he wants to do exercise, or exercise would help his diabetes, you can tell him, do you know that exercise is natural insulin? Like when you exercise, you might decrease your medication dosing. He might move from pre-contemplation to contemplation. We'll see many, many techniques through motivational interviewing and empowerment that we can discuss later. Weight loss is purely math. Calories in, if it's more than the calories out, you'll gain weight. And if it's the opposite, you lose the weight. Something from that, between those lines. Now we're shifting to stage 2, which is contemplation. The patient likes the idea, but he is still on the fence. Maybe the patient is planning to start the change within 6 months, but and on the decisional balance, he sees the cons still bigger than the pros, but not as big as the pre-contemplation. Still low conviction, not very, very low, and low confidence that he's not really confident that he can make the change. And it is our job as healthcare providers to grow with the patient up the curve from pre-contemplation to contemplation, and so on and so forth. How to handle a patient stuck in contemplation? Motivational interviewing, we will discuss that as agreed, and use facts as you did with the pre-contemplation, but use more emotions at this stage. So refer to a successful role model. A patient looks up to a soccer player, a cricket player, or a family member that achieved the same target that we're discussing. Maybe you can magnify health risks. Maybe the patient does not know what cholesterol can do. Cholesterol does not taste like anything, that does not look like anything, but it only shows as myocardial infarction or a heart attack or an MI or a stroke. So the patient might not know that, but maybe you can magnify the health risks. But I would say that with caution, because not all patients like the scare tactics. It might work with some and not with some, so I'll leave the discretion for you. You can highlight how his decision will affect his family. So you can discuss that, how the decision of the change will affect his family positively, and the effects on his family if he did not change negatively. So you can actually engage the whole picture, not look at the patient as an individual. Also, another technique is self-evaluation and environmental evaluation. And this actually goes hand in hand with what Dr. Wasif said. There is no single approach or a prescription to change a patient behavior. We mentioned the checklist, and we're mentioning many, many techniques and tools. This is your arsenal. You pick and choose whatever suits you and suits your patient and will give the better outcomes. And you might end up using many. And we will discuss what I mean with that when we go through some examples. So self-evaluation and environmental evaluation. You evaluate the barriers of the patients, and also you evaluate the opportunities that you can grab and help the patient make the change. For example, a patient having long working hours and he's forced to eat junk food because he's only a truck driver and always on the streets, and he only on his way he has McDonald's, for example, so that's all that he can eat. When you interview the patient and you know those pieces of information and you check if he's married, he has a family, someone is taking care of him, how about packing your food, lunch and snacks with you to work? And this is one of the best advices that you can give someone that is struggling with weight loss because of junk food that is being eaten at work because of long working hours. Stage 3, preparation. This patient has the intention to change within 1 month. He already took positive steps in the right direction, but he bought the shoes but kept the receipt in case he wants to do a refund. So this patient bought the shoe, he wants to exercise, kept the receipt or the gym membership receipt in case of he's gonna cancel it after a week or so. So he's still, the cons are equal to the pros. He took positive steps. He's convinced, he's confident that he's gonna make the change, but he needs support from your end. How to handle a patient in the preparation? You have to praise a patient for taking a positive step. At my practice in my pharmacy back in the day, when I have a patient coming and asking about a blood pressure monitor to monitor his blood pressure, or a glucometer that he wants to take care of himself, or he wants a smoking cessation solution, I would first thing before giving him an option to buy, I would congratulate him for taking the first step of the 1,000 miles. And I'm telling him, I'm going to assure you that you're going to succeed. I am here to support you. And patient can make a public announcement also. You can support your patient to make a public announcement to support him in the preparation phase, like Facebook people put pictures at the first day of weight loss, and they tell people to cheer for them and support them until they have an after better picture, and so on and so forth. Or I'm quitting smoking, support me, help me. I'm going to do a 1 month challenge and then go from there. As Dr. Wasif said, offer support groups and social programs. There are many, depending on the country. There are support groups for diabetes, support groups for adherence, support groups for smoking cessation, alcoholism, addiction, many groups. Those groups can be for cycling. You just need to lead a healthy lifestyle. Go on a group that supports cycling, cricket, walking, jogging, things like that, depending on the goals that you're supporting the patient to achieve. Stage 4 is action. The patient started and maintained the behavior for less than 6 months and not more. And by the way, this is the highest relapse rate. And it is, I don't want to say it's normal, I want you to be prepared. As a healthcare provider, if the patient relapses, this does not mean it's the end of the world. You can also bring him back on track. It happened before with people. Now the pros are more than the cons on the decisional balance. It's the patient is very convinced and he's very confident because of all the support that you gave him, and because of the actions that he took, and because of the results that he started seeing. Handling the action, be a cheerleader and start doing stimulus control. For example, a patient that is a smoker and you helped him stop smoking and he's already in an action stage, you can advise him to remove ashtrays. Or for example, a diabetic patient that wants to lose weight, and evidence has supported if you have a bowl of salad or just cucumbers and things in front of you, when you're passing by, you're going to always grab for something that is in front of you. If this was chocolate or donuts, they will grab chocolates and donuts. If this was an apple or a cucumber or something, they will still grab it. So you can give them you control the stimulus, remove the bad stimuluses or the stimuli in front of them and replace it with a better stimulus. He can put some nuts in front of him instead of eating chocolate, and so on and so forth. Counter conditioning is offering alternatives. For example, if the guidelines say you need to do moderate to vigorous exercise, this does not apply for every patient. Diabetic patients they have comorbidities, might have issues with their knees and back because of the overweight and walking, and you can scratch the running and tell him to walk. If he cannot walk, you can tell him swim. So counter conditioning will show on this exercise, on this slide. So for example, a patient, I want him to decrease his salt intake. I can advise him to use vinegar instead of salt for the flavor, also herbs and lemon juice. If the patient is used to cola drinks, we can also recommend the tonic waters that don't have calories and so on and so forth. So you can always give a healthier option to your patient to help him in that stage. The patient in stage 5, he maintained the good behavior for more than 6 months. So you congratulate that patient also and reinforce and give him support. And you tell him that you are there as needed. And so there are some tools to determine the stage of readiness. They're not validated, but we still use some of them. Interviewing, the way you interview the patient, you will actually get an understanding where he's standing. He's telling you, I tried and failed, I'm not going to try again. That's a pre-contemplation. That's just an example. Questionnaires and scoring systems and schemes. There are questionnaires. You tick from the domains, it translates to a number. The number takes your patient into a bucket and it tells you this patient is standing there. Schemes, I have an example here that we used to use for smoking cessation. You're interviewing the patient, you ask him, are you currently smoking? He says no. Did you quit in past 6 months? Yes. Then he is in action. If he is more than 6 months, so he's in maintenance. If yes, he is currently smoking, then are you seriously quitting, considering to quit? No, he's in pre-contemplation. Yes, he is, and so on. You go into the scheme until it goes down. We'll discuss a quick case. A patient approaches your counter to pick up a glucometer for the first time, and he decided to control his diabetes to improve his health. What is the stage of readiness of this patient? From the slides and from what we discussed, this patient is in the preparation stage, and if we apply the concepts, he took positive steps and he sees the pros equal to the cons and came for help. So now we'll shift gears to the motivational interviewing that we mentioned that we're going to rely on to help the patient go up the curve from the pre-contemplation stage to contemplation, and we use it also in the contemplation stage onward. So motivational interviewing defined, it is a patient-centered counseling style to spark the patient's own motivation to change a behavior. So we use the patient's own motivation to change a behavior. So we help him to go and grow up the curve. And it is a patient-centered approach. This is what Dr. Wasif said. We only focus on the patient in front of us. We don't focus on general guidelines and one size fits all. It's patient-centered and it's tailored and it's individualized. And it's the patient's own motivation. The patient finds the problem. The patient finds the solution. You moderate. And this is back the curve. So the motivational interviewing addresses ambivalence in the pre-contemplation and the contemplation stages, as you can see. And motivational interviewing is based on the empowerment philosophy. And we will discuss that now. So the new empowerment model versus the historical Socratic compliance model. So compliance now became a bad word. So back in the day, the Socratic model was take that prescription as directed 3 times a day. If it did not work, then it is the patient's fault. That's not fair. So now the empowerment model, it is a partnership of equals. You and your patient are equals. It is not an expert-recipient relationship because your patient brings a lot of experience like you. So you can also draw from the patient experience and help his case and moderate and help and support. So you're not there and your patient is lower. He brings or she brings a lot of experience. It is an autonomous relationship. You respect the patient autonomy. It is not paternalistic relationship. So you tell your patient, you know what is good for you, and you don't tell him, I know what is good for you. I'm not paternalistic, but rather autonomous. A patient takes informed decisions and actions based on his awareness of the possible consequences of not changing his behavior. So after the interview, the patient created an understanding, and he knew if he continued his bad behavior, he took an informed decision, it will not take him to his goals. So he should start making the possible changes and bear the possible consequences of not changing because of our informed decision. Also, another concept for the empowerment and motivation interviewing, adults are more likely to make and maintain a behavior change if the changes are personally meaningful to the patient and they are freely chosen by the patient. Freely chosen, this is what Dr. Wasif mentioned, collaboration. You do not dictate. So healthcare providers only guide, but they never lead the conversation. They only guide the patient. The patient finds his problems and finds his solution while you guide him through the interview. So the hallmark of empowerment, motivation, and interviewing is shared decision making, which is what Dr. Wasif said, and individualized patient-centered goals. So if you have this slide, it covers everything. We have some few ideas as well about motivation, interviewing, and empowerment. It's acceptance with non-judgmental manner. So you only give your patient unconditional positive regard, regardless of what the patient says or does. Your patient comes to you because he's not taking his medication. You don't tell him, oh, that's bad. Why did you do that? You should not be judgmental and you should be accepting. Accepting how? You can tell him, I know it is very challenging for some people to continue on medication. You just give him an acceptance statement. Always explore the patient feelings regarding the problem and the change. Remember how many times Dr. Wasif mentioned psychology, psychology, psychology? We are shifting into that when we're dealing with the behaviors of our patients. We have to understand psychology. So you have to explore the patient's feeling. So you can ask him, how do you feel about exercising? Before telling him, take this 3 times a day, and those are the side effects, exactly in agreement with what Dr. Wasif said. How do you feel about diabetes? How do you see it? Oh, I can manage it. I'm strong. Or I'm done. I'm gonna die young. And da. So those feelings can give you a better understanding on how to deal with your patient. Now the principles of motivational interviewing are 4. We discussed the philosophy. Now we'll go into nitty-gritty principles. Show empathy. Number 1. Showing empathy can be by many, many means. Acknowledging that ambivalence of the patient is normal. You tell him, oh, I know it's very tough to change and sometimes it's challenging, da. Actually, telling the patient, I'm here to help you. We'll get some examples and we'll go through that together. Create discrepancy. You tell the patient or summarize his story from what he told you, that you want to do this good behavior to reach that goal, but your current activity But your current activity is not going to take you to your goal. This is creating discrepancy. Rolling with resistance. As soon as the patient is resistant, know that to avoid argument, you need to know that this is a sign of changes in strategy, and we'll discuss examples. Supporting self-efficacy. You need to support the patient's confidence. You need to give the patient possible solutions and discuss it with him. And don't tell him run 5 times a day. Tell him, do you like exercise? What kind of exercise you're comfortable with? And you see from his conversations and you guide him through it. So showing empathy examples, I'm sorry to hear that you are finding it hard to lose weight. This acceptance statement is empathy. I will be more than happy to help you. That's sympathy. Do you mind if I ask you some questions and take some notes? Taking permission to ask questions is empathy. Taking permission to take notes is empathy, so it doesn't look like an interrogation. Creating discrepancy. From what I understand, you want to lose the weight, but you consider your eating habits at the moment are unhealthy. So you summarize and you put it in front of the patient, you put the problem in front of the patient in a manner that is not judgmental. Roll with resistance. I know you don't want to let go of eating pizza. Do you think you can have one cheat meal a day? That's me. One cheat meal a week. So this is rolling with resistance. Supporting self-efficacy, and this is a very important slide. Can you tell me one thing that can help you succeed in losing weight? He can tell you, I can lose weight if I have a gym membership. Oh, now he's giving you solutions and he's convincing himself. Gym membership, but he cannot afford it. Oh, he cannot afford it. Then can you suggest a mobile application that he can work out at home and it's free? Things like that. Can you tell me one reason that is stopping you from losing weight? He can tell you his obstacles. Don't assume that you know his obstacles. The patient will give you what is stopping him. And as he's speaking, he's actually convincing him of the positives of changing and the negatives of not changing and the obstacles. So now we're going to get one quick patient case scenario. A patient tells you about his struggle with losing weight and how his health has been going downhill year by year. He is seeking your advice. Someone would tell him, you are obese, this is not good for your heart and may easily cause a heart attack. You should exercise 5 times a week, stop eating junk, and eat a lot of salad. If we apply the MI principles, you are obese, this is judgmental, no empathy, and it's offensive. If we look at you should and stop eating, that's paternalistic, not acceptable. If you should exercise 5 times a week, that's not patient-centric. This is guidelines. Is the patient able to exercise 5 times a week? How is his heart condition? How is his knees? How is his back? Those things, it's not patient-centered. Eat a lot of salad. You assumed that he doesn't eat salad. Maybe he's a salad eater, but he eats salad and then gets a dessert of chocolate. Pre-contemplation among the audience, among you guys. Someone might say, I'm too busy, I cannot apply this at my busy pharmacy. And I would tell you 1 patient a day is okay. There is strong evidence that education as little as 5 minutes with your patient can make significant quality of life changes to the patient and outcomes. And I would quote Prophet Muhammad sallallahu alayhi wa sallam, إنما العلم بالتعلم وإنما الحلم بالتحلم. Verily, truly, knowledge is acquired by learning, and if you want to show humility and patience, you have to practice humility and patience. End of quote. Thank you so much. My presentation came to an end, and I hope you enjoyed it, and we'll be more than happy to take any questions that are related to my presentation and Dr. Wasif's presentations. Those are the references, and thank you so much.
Thank you so much, Dr. El-Gamal and Dr. Wasif Gillani. So we have 2 questions. So quickly we went through those questions. Questions from you, Dr. Zeyad. How can I balance not getting reimbursed for my time and spending a long time counseling patients?
Okay, so number 1, practice makes perfect. And when you become better at doing what you're doing, then you become efficient. When you become efficient, it's going to be second nature. That's number 1. You have to be fast and efficient. That's number 1. Number 2, from my understanding, I need to add value. If you are the only pharmacist among 10 pharmacists at your counter that is doing that, and the patients are coming and asking about you, and we have this example, real life example, a caregiver that spends time with the patient, and he's a sweet talker, and he is very, very professional, and he deals with the patient, all the angry patient, he deals with them. The pharmacy leadership where I practiced back in the day, they changed the KPIs for this pharmacist. You need to see 80 patients a day, but you need to see 40. Why? Because we know that you add value. You be the change leader. You be the first person to do the right thing. I know we're all overwhelmed by KPIs, metrics, and capitalism, but yeah, be the change ambassador. Add value, then you will be valued. And there are many, many countries that those kind of services, they are paid because there is evidence to support it. Without having a pharmacist, those were the outcomes. Plus a pharmacist, those were the outcomes, and they improved. And this is what I would encourage all the scholars and the pharmacists and the scientists who are working on research. Those are the kinds of research that we need, the research that values the added participation of a pharmacist to be reimbursed for the efforts that they spend. And I hope that I answered the question.
Right. So,
Thank you.
Dr. Wasif, I have a question for you. What should be the clinical and objective parameters or tools to assess the adherence for a diabetic patient, keeping in view the three pillars of adherence you just have mentioned?
Uh, Azhar, it's a very difficult question.
Just
The
like,
reason is, the reason is until now there is not a well-developed questionnaire or a tool that covers all the three pillars, or that covers all the five pillars. That's why we need multiple tools to evaluate multiple dimensions of the adherence. And I believe that maybe in the future, if anyone of our competent pharmacists want to work with us and want to do research and develop this tool, I am more than happy to assist them, and I will be more than happy to be a part of this project. Because until now, in my whole research career, with my about 150 publications, I never see a single tool who has all these five elements of domains of adherence.
okay, well, thank you so much, Dr. Wasif, and thank you so much, Dr. Ziyad, for your precious time. And on behalf of Giving Back to Pharmacy in Pakistan, I would like to appreciate the audience who are still with us. And you guys, you take time from your precious activities. And from my side, thank you so much. And then now we're going to end this session officially. Take care and
Take
have
care.
a good rest of
Take
your
care.
day.
Thank you
Thank you
very
so
much.
much. Appreciate it. It was a pleasure. Thank you.
It's an honor. Thank you.